Hello, good morning, everybody. We thank you for taking the time this Saturday morning to join us in our webinar entitled, I Got a Curve Back, What Should I Do? I am Dr. Guo Changming, Senior Clinician and Surgeon in the Department of Orthopedic Surgery and a spine surgeon myself. Scoliosis is a very interesting topic because it involves many people, including people of all ages, from the very young and also to the very old. So during this 1.5 hour seminar, we hope to share some of the highlights and some of the treatment options that are available for patients with this condition. For this morning, we have three prominent and eminent speakers. I'll be introducing them one by one. As they gave their presentation, which is about 20 minutes each, you can also take down and post your questions in the Q&A button, which is located in your laptop right at the bottom. So key in the questions. We have about 25 minutes and we will try to answer some of the pertinent and direct questions on scoliosis and deformity during that period. So without further ado, I'd like to introduce our first speaker. His name is Dr. Ruben So. He is a consultant spine surgeon and a dear colleague of mine. He's also very passionate about spinal deformity, both in children and in adults. He's a deputy director in our SingHealth Duke Spine Center, and he's also a member of the Scoliosis Research Society. Dr. Ruben So.
Thank you, Prof. Guo, for the kind introduction. And I would like to just welcome everybody once again to this webinar. Right now, I think we are all rushing for a bit of time because we have a lot of content to share with everybody. So without further ado, I will just start my presentation. So first of all, I think today my talk is entitled Advances in the Patient Journey in Adolescent Scoliosis. And the reason why we want to share really is that there are a lot of new advances and a lot of my patients are not aware of these advances. And we also use this opportunity for the June being the World Scoliosis Awareness Month and thankfully also a time during the school holidays that everybody can come together to have this short 1.5 hours. So before I start, of course, I think when we look at this, we want to recognize, first of all, what is the definition of scoliosis. And so when patients see us, they say, okay, I got a bit of a curved spine, but sometimes their curved spine isn't that bad. And so 10 degrees is really what we use to define the measurement. How does it occur is that you can look at this is the red lines, they are highlighting the most curved part. Perpendicular lines are then drawn from the red line. And then this is what we call the Cobb angle. And this Cobb angle with more than 10 degrees is defined as scoliosis. It's probably easier to see on this schematic. And while we use the frontal view of the spine to define what is scoliosis, actually it's a three-dimensional deformity, both from the side view, the sagittal view, as well as the view from the top, which is what we call a rotational deformity. So most of our patients, you can see, actually are within the blue box. They are quite straight looking, but actually they don't really have much curves. They don't have really a lumbar lordosis or a thoracic kyphosis, as you can see here in the image here. But they do have quite a fair bit of rotational deformity, as you can see here in this graph picture, which is a reconstruction of one of our patients who has scoliosis. And you can see that the bones are not pointing all in the same direction, which is a sign that this is actually a three-dimensional deformity. So how do we treat patients in Singapore? We have the school screening program in place since 1981. It's certainly more commonly seen in girls, and as the curve becomes bigger, maybe at the 40 degree mark, it's probably 4 females is to 1 male. And because those mature a little bit earlier, we start the screening program at primary 5 for females, while secondary 1 for males. And when the school screening program brings them to the health promotion board and the nurses and the doctors are seeing them there, those who require specialist treatment will be referred to the 3 centers, Singapore General Hospital, KK, as well as the University Hospital. I'll share a bit more about what they use for screening. So I'm not sure if many of you remember what the nurses are doing in the primary school, but they will get the child to bend forward. And using this scoliometer, it gives an indication of where is the rotation. And this number that you see that is being displayed here will give us an idea of how much curvature is there in the spine. Now, this is quite a useful tool for screening. And this tool is the one that is being used across Singapore to then intervene early for patients who have mild scoliosis so that they remain having mild scoliosis and do not progress into moderate or severe scoliosis. Now, the types of scoliosis that are present, of course, there are many types. And the most common one that we see is this group, those who are more than 10 years old and called adolescent idiopathic scoliosis. Having said that, you see there are many other types here. And I think our role as specialists is to make sure that the patients that come through the clinic don't have any of these other types, because then the management is quite different. Many parents ask me, so what's the causes of scoliosis? And I think that the reality is that we think it's multifactorial. We are still not really sure. And that's why the term is idiopathic. Idiopathic because there's no one single cause, and likely it's a combination of multiple abnormalities. There is some studies indicating that endocrine hormones may be a little bit abnormal in these children. There are also some genetic abnormalities, and because we see that mothers and daughters and sisters have about a 30% possibility of having scoliosis in the same family. But 30% isn't quite enough to say that there's one particular gene that is affecting the problem. So what is the specialist perspective and what is my perspective when I see the patients coming to my clinic? My first thing is, do I know that this is truly adolescent idiopathic scoliosis? Is there another cause? So I spend a good time to look at them, making sure that they don't have ligamentous laxity, as you can see in the first picture, or have some abnormal changes in the skin, because these are patients who are maybe not the typical idiopathic scoliosis. And my next question really is that the child that's seeing me right now, is he mature or immature? And will he or she grow more? Because the more growth there is in the spine, there is a more chance for scoliosis to get worse over time. Now, how do we make some sense of this? We use the time for the first menses, what we call menarche, as a marker for the ladies. When they are growing very quickly, usually around 6 months after the peak height spurt, they will have their first menses. And then after that, it sort of tapers down for a year to 2 years after the menarche, and then the growth of the spine stops. So this is a critical period where the child is still what we call immature and able to undergo interventions such as bracing, because they are still what we call in the immature and growing phase. A little bit harder for the boys, because boys tend to mature a bit later and they only have a voice change as a marker for maturity. And as you can see, the boys tend to grow a little bit longer in terms of the time. They start later and end later. And so by the time they finish their growth can be sometimes in Sec 4 or even in JC1 or first year of Polytechnic. We then proceed to do some x-rays, and while everyone is looking at the curve, actually, as a specialist, I'm not really looking at the curve, I'm looking at the other things around the curve. I'm looking at the pelvis to make sure to see whether it's fully fused. As you can see here, the triradiate cartilage is closing in the middle photo. There is also, I'm looking at the iliac crest, or what we call the Mickey Mouse ears of the pelvis. And this also gives us an idea whether the child is mature or immature. And of course, a mature child will not be able to undergo bracing as effectively because the spine is already mature. Some of you remember in the school health promotion board, you get to do this X-ray, ask you to lift up your left hand. It's not because we want you to ask a question, but really it's because we're looking at the bone age. And you can see here that the bone age changes over time. The cartilage starts to joins together over the top of the fingers, and this will then show a progressive maturity. And the bone age is helpful in helping us determine whether the child is becoming more and more mature. And like many things in medicine, not one indicator is able to predict everything. So we use a conglomeration of age, the history of the menarche, the history of the voice, history of how much growth are they growing. Then we use the X-rays to back up. And of course, we use physical examination to see whether the child is still in the growth phase or not. So this really gives us an idea of whether the child is mature or immature. And then that brings us to decision making. Because if a child is mature, they shouldn't be braced. They should actually be observed. And if they do cross the 45-degree or 50-degree mark, we may offer surgery for them to prevent worsening. But for the immature spine, I think this is where it's very important to try to get them into a bracing program as long as they fit the criteria. Now, the intervention that we can perform for them will be bracing and physiotherapy, as well as surgery. And I'll share a little bit about bracing. So, but the more important thing right now is that when we do an intervention for the patients who have scoliosis, the aim is to prevent progression. And so many parents ask me, so after bracing, will my child become straighter? And the truth of the matter is that we do see that phenomenon occur once in a while, but I would say that if the child can remain the same when the time they present to the time that they finish their bracing, I would have called it a successful bracing already. And I don't think this phenomenon where they pull straighter is that common. But if it does happen, then I think it's what we call a bonus phenomenon. So what are some of the recent advances that I think we have in our treatment after we've covered the basics? We now have low-dose radiation for scoliosis surveillance. We are also using Schroff exercises as well as exercises for scoliosis-specific exercises, so physio-scoliotic specific exercises, growth modulation, and motion preservation surgery. We are also using intraoperative low-dose radiation to ensure that there's safety and clarity and yet a low dose of radiation for the patient during operation. And importantly, we do better planning now using the three-dimensional software. So what is low-dose radiation? So this is a EOS scanner. It is actually an aperture-based X-ray machine. It improves the imaging and yet reduces the radiation by having a pinhole or slit lamp type of phenomenon, whereby the less rays are coming out and yet because less rays are coming out, it's coming out through a slit, it remains clear. Now, this on the left here is showing the first version, while on the right here is showing the newer version that we have in SGH. And you can compare the difference between the traditional X-ray, the version 1, which is what I showed earlier on, and the version 2. And you can see that for decreasing amounts of radiation, actually the image is getting clearer, which actually doesn't make common sense, but it makes a lot of sense when it comes to analyzing it from the technological standpoint. And I'm very happy to see that we have this running all the time for our patients who are coming to Singapore General Hospital. Bracing will require the typical guideline of more than 10 years of age, more than 25 degrees. And basing on the bracing criteria, that's when we introduce them to a brace. Of course, those that are having a curve that have an apex of higher than the T7, this underarm brace may not be able to help them. And as a result of that, they are unable to have this rigid brace applied. And when we look at these patients and I ask them, and the parents ask me, should we brace? The clear answer is yes, because this trial that was done in the US with a control group and an intervention group that showed that through temperature logging, that bracing is dose dependent. That means the more you wear the brace, the better the effect is in preventing worsening. And this is what we use now as one of the landmark articles that give us the evidence to show that indeed bracing is important. When do we discontinue the brace? I think that's when the growth is completed. And when in girls for 4 and for boys at base 5, and when they don't grow anymore, I think that's so important. Or if they require to go to surgery. In terms of physiotherapy, much has been written in the last few years about how physiotherapy is critical in supporting patients with scoliosis, whether it is core strengthening exercises or the Schroff exercises. I think these are important. And Schroff is just a form of physiotherapeutic scoliosis specific exercises, and there are many other types available. But it's important that these are all done not only in isolation, but also with a bit of bracing, and that will be very helpful in reducing and preventing worsening. And of course, like in all physiotherapy, compliance is important. It's no use in seeing the physio, asking them to give you all the information, but not practicing. And I always remind our patients and our parents that it's important to set aside some time each day to do the physiotherapy treatment. So this is a picture showing some Schroff exercises, one of the PSSEs, and I will let Dr. Jun Kwek elaborate a little bit more about this later. But essentially what we know now is that there's good outcome when curves are between 10 to 30 degrees. And a period of treatment is important because they need some time to mold the spine according to the exercise that's being done. And when we look at the meta-analysis, which is a whole collection of papers that analyze this, we can see that there is a beneficial effect. You see all the black dots, they're falling beyond 0. So they all definitely show that there is beneficial effect when it's using these Schroff exercises on idiopathic scoliosis. How about the new advance on growth modulation surgery? And the real question really is there a way to allow this spine that you see here on the right side to grow slower, and on the left side where the deep curve is to grow faster? And as per these arrows here. And on top of that, is there a way that can preserve motion while treating the child? The answer is that yes. And so what we know now is that there is hemiepiphyseal disease or guided growth. We can allow the convex side, which is the curved side, to be slowing down its growth, and to allow the catching up of the concave side. And this growth arrest is a modulation of growth. Now, how does it work? Essentially, a growing bone that is under compression will grow less, whereas a bone that is on traction will grow more because the growing bone behaves that way. And so if we can get the side of the spine, which is growing fast, to be compressed, then what we can do is we can slow down the curve on that side and then get the concave side to catch up, as you can see in this picture here, where we place some implants into the spine on the convex side, stop it from growing with a cord, and then over time, it will catch up the growth on the concave side and then allow the spine to straighten by itself, as you can see here in this picture. And so tethering is one of the newer things that's available and good for the patients that are a bit younger, because they must have some growth to allow nature's biomechanics to catch up. It is minimally invasive and it's motion preserving, which I think is great. So it's minimally invasive. As you can see here, there are very tiny holes in the chest wall, and it's a scope is done during the surgery to ensure that the location or placement of these screws is accurate and pinpoint. And the candidates who can do this basically are those that have much growth potential left. They must be steadily immature, and they should have a Sanders score of between 2 to 5. And this is what it looks like on the sawbone model. A cord on the side of the convex side. So this is a case example, a patient who was required surgery. She clearly required surgery because she's past 45 degrees. She had the tethering done, and over the next 12 months, she slowly got better naturally because of the growth of the concave side. What other things have advanced? I would also say things with regards to surgical management. So preoperative planning, such as the use of MRIs, is important. I tend to not use any CTs in the pre-op planning because I really want to reduce the amount of radiation for my patients who have idiopathic scoliosis. But what we do is an intraoperative CT scan. And this intraoperative CT scan is low dose. And I would say that some of the game changers that have been helpful in the surgical management of our patients has been the use of intraoperative navigation, the cell saver, and use of neuromonitoring, where we can monitor the patient's nerve function during the entire surgery to prevent that dreaded risk of a complication such as having weakness in the legs or paralysis. So intra-op navigation is using the, what we have is the O-arm. This is the intra-op CT scan. We were the first in Asia in 2007 to have this, and we continue to use it till today. Basically, what happens is that in a patient who has scoliosis, one side of the spine is a bit broader. You can see on the left, the regular pedicle is wider. The small pedicle is on the right side of your screen. And we really want to be able to put a implant into the vertebral body to control the rotation. And so using the navigation, we are able to then slowly put it in without having to risk going into the spinal canal. Now, one of the newer things that we have is actually, once again, we're first in Asia to have further reduction in radiation. So you can see here in the top right-hand corner, this is under scanner to capture the image, the smaller one, to let the radiation dosage is reduced to 52%. And at the same time, you can see that the images that are showing the navigation occurring, and as I move, it's real time. And so this real time, low radiation procedure is something that really is going to be a game changer in the way that we manage our patients, because we want to make sure that they have as little radiation as possible, no preoperative CT scan because there's no requirement for it, but they will have the non-radiation scan such as an MRI scan. How about the use of three-dimensional planning? So I think some of you have read the Lian Zapao article last year. We in complex cases, we do sometimes need to print the 3D print the spine. And in this case here, you can see that the 3D printed spine is put into the surgical field to make it safe so that we know where to go and how to negotiate a difficult case. But in not so difficult cases, in the more routine adolescent idiopathic cases, we use the additional data from the EOS that was done as part of the surveillance to map into this three-dimensional model. And this three-dimensional model allows us to know where the rotation of the spine is going, and that allows us to understand how do we then correct it in a very accurate and nice manner, as you can see here in this picture on the right. So when it comes to surgery, really the aim is to stop curve progression and correct deformity. And you can see here that this patient had brought her back to the midpoint when it comes to the balance. And we thankfully have many successful patients, and of course they like to come back and they like to take a lot of pictures. And in this social media age, I think all of us are also being followed by our patients as well along the years. Now, when it comes to, of course, scoliosis care, it is definitely a team effort. And you can see here in this picture, physios, nurses, allied health, everyone is involved in the care. And on top of that, we have patient support groups who have undergone the treatment before. And they also have care for the surgical side. They have some advice on activity modification. and we continue to use X-ray monitoring using the EOS in terms of the follow-up. Now, I'd like to point our audience to online resources where you can get a little bit more information. You can see on the bottom left-hand corner, you click on patients and families. The Scoliosis Research Society has lots of information for you to surf onto to understand a little bit more about scoliosis. And this is a non-doctor group. I think it's called Scoliosis Support Singapore. It's been around since 2004. So for those who are interested and want to listen to those who have had scoliosis and have treatment before, whether it's bracing or whether it's surgery, this is an active group that continues to support all those who have scoliosis, and is run by volunteers, as you can see here in this photo. So really, in conclusion, we have the patient journey really starts with diagnosis. Then they will then probably have observation, bracing, and physiotherapy, and possibly surgery. And I think the new advances that we can share with the group today really is compliance is key to the exercises and the scoliosis specific exercises. Bracing remains important as well in non-operative management. We use quite a lot of low-dose radiation today via the EOS as well as the cone beam intra-op CT, as you saw earlier on in the video. Pre-op planning with 3D modeling also makes the treatments much safer, and we are becoming more confident with regards to the way that we know how the spine will behave when it comes to doing the surgery. And we are also doing motion preserving and minimally invasive scoliosis surgery for those patients who have some growth left in their spine, so that they are able to then maintain their mobility and yet use the natural way of the body to catch up the growth in the concavity through the use of vertebral body tethering. And with that, I thank you for your attention, and we will welcome all the questions through the Q&A box. Thank you.
Thank you, Ruben, for the wonderful and interesting presentation. You have covered both the options for the children who have scoliosis, their treatment options, both conservative and also surgical options, and also how the new advances in the surgical management could help these patients have safer surgery. Next up, we have Dr. June Quek. She's going to be speaking on the topic of spinal movements and physiotherapy in scoliosis. Dr. June Quek is the principal physiotherapist in Singapore General Hospital. She has 20 years of experience under her belt. Dr. June Quek has a special interest in spinal physiotherapy, where she did her PhD on that in Queensland. So I'd like next to present Dr. June Quek, spinal movement and physiotherapy in scoliosis. June.
Thank you, Dr. Goh, for your kind introduction. So this is the topic of my talk today. Let's see. So this is the outline of what I'll be speaking on. The what, the why, the how, and the who. Basically, I will be going a little bit more in depth about the physiotherapy scoliosis specific exercises, and I'll touch a little bit on the differences between that and general exercises. The whys, the goals and expectations of physio, what do we do, and I'll be touching both the adolescents as well as adults, but very briefly. Just to reiterate what Dr. Ruben talked about scoliosis definition, it's really important to understand this definition, because our exercises will be based on how the spine is deformed. So the definition of scoliosis is a complex process of trunk deformation which moves from a sagittal plane to a complex torsional geometry in three-dimensional space. In this X-ray on the right, you can see that you are really looking at the coronal component, where you see the side bending of the thoracic spine and lumbar spine. But very often we do also see rotational scoliosis, which is the spine just rotates but also in the sagittal plane, which is the side view, you get patients with flat back syndrome or more curve, as in to go into more kyphosis. So no patient is the same, as in no curve is the same. So that's why at physiotherapy, even though we give general exercises, but very specific to scoliosis, we actually have to assess the individual curves and then prescribe exercises based on the curves of the patient. So there are many schools that do physiotherapy scoliosis specific exercises. So I was trained in ISST, the first one. The most common one that you probably have heard of is the shock therapy. And then there are the others like the C's from Italy. I mean, the shock is originated from Germany. And then there are other countries that actually come up with their own branding. Very important to understand also is that physiotherapy undergraduate programs don't actually teach this. So we have to go for extra training to be able to teach scoliosis specific exercises. So when a patient comes into the clinic and referred by the doctors, having this conversation education is really, really important because we need to realign expectations and all. Usually patients are in the clinic because they want to avoid surgery, or maybe their curves are not so bad. So they want to at least to prevent and delay further progression of the spinal curves. Also during the session, we will definitely be emphasizing on postural awareness. How do they actually sit or stand is really important. And so to help them understand that them sitting in a very asymmetrical position is not helpful for the progression, to prevent the progression of the curve. So the other thing is during the physio, we will also be teaching patients how to expand their chest. So if you look in this picture on the right, the X-ray, you can see that the thoracic spine, which is the upper part of the curve here, is elongated on the right, and then is compressed on the left. So technically, you will see that the lungs on the right is elongated, expanded, and then on the lungs on the left is actually compressed. So when you put your hands on the patients, usually you can see that the breathing will be bigger or more expansion on the elongated side. So for physiotherapy, when we teach them the exercises, we reinforce the fact that you have to breathe into the area that is more compressed. Okay, so how to do that? Use tactile stimulation and all that, and the goal is to really to expand the ribcage. As Dr. Ruben mentioned, compliance is key. There are many research going out that has been published that compliance actually produces much better results in terms of delaying the curve or even improvement of the curve. And also the other thing is relationship with building relationship with the patient as well the parents is really important, as well as working together as a team, the surgeons, the orthosists. It is very important that the patients themselves get holistic management. Yeah. So what we'll not be able to do is to regain your sexy body back, and also to actually straighten up the spine, as Dr. Ruben also mentioned, that is really that the evidence is not very clear or does not support a reversal of the curve for physiotherapy, but really to prevent and delay the progression of the curve. Okay, so during the physiotherapy, it's really important to actually capture the period in which the patients will have most benefit during their growth spurt. So 1 year before their puberty and 1 year after. And like Dr. Ruben said, that the females is easy to tell because that's a period where they have their menses. And then for males, really just the voice change is the indicator. Also, the other thing is that as I mentioned, not all patients are the same. They all come in different shapes and sizes, as well as different biomechanics, the way they stand, the way they sit, the way their foot is postured, or the way that they are standing. Some of them may have leg length discrepancy. Some of them are more active, they are more taking part in competitions, and some are sedentary. So it really depends on what patients' goals are, and how we then come in to help support their goals. Okay, so I thought I'll share a couple of examples of patients who are in the clinic. So really thankful for those patients who agreed for their photo to be put on here for everybody to learn. So as you can see, this patient so this is her usual posture. If you look at the shoulder, the right side is more forward compared to the left. And she has a upper thoracic curve to the right, and then to the left of the lumbar curve. You can see that she's, it's not very obvious, but you can see that she's actually sitting more towards her left, like weight bearing more towards the left. Then you can see also from this line here that her head is tilted to the right. And then from the front, you can see the head is actually rotated to the left. So this is a usual posture. Then on the right, by we use some equipment like bean bags, towels. We place a towel here, and then we use sticks or sometimes the parallel bars, the wall bars, and help improve to derotate the curve, and also to align the curve in a more vertical position. Yeah, so this is how she's curved, and the therapy is to address these curves. So this is another 13-year-old female, and both were given brace to use, and you can see that her standing posture is leaning to the right of the top, but at the pelvis is leaning to the left. So this is her X-ray, and part of therapy is to show her what postural balance is. That means not allowing her hip to go out that way, but to show her using mirror feedback to realign the hip in the more centered position, and as well as here. So this is an example. And on the left, you can see that she's lying down or on the left, and you can see her right shoulder is down, left shoulder is up. Not very clear here, but her curve on the top is like this. Okay, so then you can see the rib hump here and a lumbar prominence over here. So during the exercise, we try to realign the spine. We use towels to prop the spine up according to the curves. And you can see the difference between before the exercise and then after exercise, the spine is straighter. So I thought I'll just share a video of exercise that we do at clinic. Okay, so first step is put the towel under your left butt. Okay, then elongate your spine. Okay, shift your right trunk center, good. Okay, and then now use your hands, correct your curve. Push your left hand. Yep, don't lose your corrected curve. Yep, elongate. Okay, good. Elongate, good. And breathe. Good. Don't lose it. Yep, elongate. Elongate. Yep. Okay. Okay, so you can see that actually the exercise is not easy at all. This patient could not do this during the first couple of sessions. So we had to start with a more basic one, which was the sideline one that we showed you before. Because the exercise is take some time to understand, and the patient themselves need to know, have a little bit more awareness of how they're sitting and standing, and then correct themselves in those positions. So you can see before the exercise, that's how she normally sits. And then during the exercise, the spine is more realigned. I mean, not perfect, but better. So the success of the scoliosis specific exercise really depends, highly dependent on the compliance and commitment to exercises, and to maintain their postural balance in the sitting, standing position. I mean, the research is showing that at least half an hour a day or 4 to 6 hours a week. So, and with the race, there's a consensus of wearing at least 16 hours a day. Of course, the more the merrier. Supportive parents as well really helps, because the parents can then encourage and do the exercises with them. Regular physiotherapy sessions, usually we do at least have 5 to 6 sessions in total, but I think because the exercises are really not easy to get at all, so it really depends on how bad the curve is, their growth period, as well as whether the patient is making any progress or understand. So it may take more sessions or it may take less sessions. So it really depends on the patients. Experience of physiotherapists also is key. So moving on to scoliosis in adults. Unfortunately, it's complex because it is complex. It is complicated by other things that the adults actually have, things like osteoporosis as they grow older, pain, deconditioning happens as physical activity becomes less over the years, and also other factors, lifestyle factors like diet, smoking, sleep, and stress. So with regards to physiotherapy in adult scoliosis, there is no evidence that it's possible to reverse the curve, but physio may be effective for pain. And also there is limited evidence on delaying the progression of the curves as of now. So when patients are referred for physio, we don't really treat the curve per se. Usually patients come with issues like pain or discomfort or weakness, and then we assess, establish what they actually want from the session, and then we treat accordingly. So the same thing with adolescents, goals and management plan. We emphasize on compliance to exercise and postural balance, so the way you stand, and if it need be, we can prescribe specific exercises for the scoliosis curve. With the adults, it's more complicated because they have been growing with the curve over the years, and sometimes correcting the curve may actually induce more pain. So I think for the first up, we want to reduce the pain first, and then slowly work through the impairments that we see, whether is it weakness, whether is it stiffness, and then establish the goals that patients want to achieve. It's really important for adults to be physically active. I'll say 3 to 5 times of regular exercise a week. Generally, we encourage strength training as well. And for those with osteoporosis, definitely regular weight-bearing exercises would benefit these patients. So I guess in conclusion, for adult scoliosis, it's not so straightforward because adults actually have more years to develop postural imbalance, have more years to develop, like things like osteoporosis and lifestyle issues that actually affect their outcome. So I would say that because actually scoliosis in adults is not uncommon, we would treat them as anyone with who comes in the clinic with back pain. And if the specific exercises for scoliosis actually do help their pain, we will actually introduce that. So it's very dependent on each patient, and there's no one size fits all kind of a therapy. So just a little bit on scoliosis specific versus general exercises. I will say that we need both for adolescents, and there is evidence to show that adolescents have a better result in the COP angles with scoliosis specific exercises, whereas in the adults, there isn't much evidence or limited evidence because this area is still evolving. But absence of evidence doesn't mean evidence of absence. It's just that it hasn't really been researched much. And hopefully over the next few years, next 10 or 20 years, the research there'll be more research on this for adults. Yeah, that concludes my talk. I'd like to acknowledge orthopedic surgery department SG, especially Dr. Johnson and Dr. Brunso for being so supportive for us in physio. My HOD and my colleagues for supporting me in this journey. Also, the physios in KKH have also been really collaborative in working out relationship and helping us in SGH start this service. And most importantly of all, parents and patients who gave permission to use their photos and videos. Just shout out to those of you who might be interested that there is this ISSD Shroff camp going on. If you're interested, please contact Sarah. It's actually a 6-day camp. Both adults and adolescents or kids are welcome to attend. They do have limited space. I think like only 8 vacancies. Thank you very much.
Thank you, Dr. June Quack, for the most interesting presentation. Next up, we will have another interesting topic, this time on adult scoliosis. This will be presented by Dr. Oh Yang. Dr. Oh Yang is a consultant spine surgeon in Singapore General Hospital. He has a diverse interests in both scoliosis surgery, minimally invasive surgery, and also arthroplasty. He's also one of the senior doctors in Singapore General Hospital. Let's listen to his interesting topic entitled Upright, Alright, an inside look in the management of adult spinal deformity. Dr. Oh Yang.
Hi, good morning. Okay, let me just start my slides. Okay, hi, I'm Clinical Assistant Professor Dr. Oh Yang, and I'm a consultant spine surgeon with the Department of Orthopedic Surgery in Singapore General Hospital. So first, I have no conflicts of interest. And before we begin, we have to define what the problem is. And so what is adult spinal deformity? So this is spinal deformity that occurs in a patient that is already skeletally mature with a COP angle of greater than 10 degrees or a sagittal vertical axis of greater than 5 degrees. In my next slide, you can see this lady is tilted forward, and this is quite different from what Dr. Ruben had presented earlier with a forward tilt of the spine. So why do we develop spinal deformity? So spinal deformity actually commonly develops from the degeneration of the intervertebral disc. This is the soft part of the spine that allows you to have movement and flexibility. And with aging, the disc actually undergoes degeneration. It can flatten and it can change in shape. And this ultimately results in a change in the overall posture of the spine. Next, the shape of the bones themselves can be altered, and this is usually due to multiple fractures and osteoporosis, leading to a very common sight in which the elderly walk with a severely hunched back. Thirdly, this could be due to a progression of existing disease from adolescent idiopathic scoliosis, And this is probably due to the passage of time, gravity, weight, and the loss of stabilizing muscle bulk in the later stages of life, although this is not usually so common. Lastly, some forms of inflammatory arthritis can affect the soft tissues around the spine, leading to a spine that is rigid and fused, as well as kyphotic, which is where it is curved forwards. So why does this all matter? It matters because humans are bipedal. Bipedal is the ability to walk on 2 feet. And as most animals are actually walking on 4 limbs, they are actually in a stable position, much like a table. Human beings are like trying to balance a ladder on its end, and this requires a lot of muscle activation and nervous coordination to allow you to stand upright. The ability to stand upright is, of course, useful, as it provides us the ability to use weapons and tools, to carry things, and to see over tall grass, which prevented our ancestors from being eaten by cheetahs in the savannah. This, however, leads to a concept of the cone of economy, which was first proposed in the 1970s by Dr. Jean-Félix Dubosset, in which he believed that the upper body was limited to a narrow cone by which the body could function efficiently without tipping over and without excessive muscle use or activation. So putting it in action, as you can see that as the patient tilts more and more because of scoliosis, they will require excessive muscular activation in the back muscles to try and pull them upright, as well as to prevent them from falling over. And this chronic use of the muscles leads to overuse, strain, chronic backaches. Another issue that is developed from adult spinal deformity could be due to the loss of forward gaze. In severe deformities, the patient is unable to raise his head up, to walk forward, and to see his surroundings. Lastly, if the deformity is caused by disc degeneration, which is the most common form of deformity, then it can actually cause a pinching of the nerve outlets, which leads to weakness, numbness, pain, and paresthesia of the patient's limbs. So if I am, having adult spinal deformity or developing an adult spinal deformity, what can you do? So firstly, as Dr. Quek mentioned just now, we can exercise our core muscles, and this increases our muscular reserves and allows us to stand more upright. We can have frequent changes, stretches, and this allows the disc to perform like a sponge in drawing in fluids, which increases its nutrition. To avoid smoking, because smoking can cause avascularity or loss of blood supply to the disc, leading to accelerated degeneration. And lastly, avoiding obesity, which puts excessive strain on the disc. Lastly, adopting a good posture allows the disc to be placed in a neutral position to avoid uneven loading, which may then cause further disc degeneration. A second preventable cause of adult spinal deformity is avoiding osteoporosis, and this requires adequate intake of vitamin D, which requires sunlight exposure, calcium supplementation, which is appropriate to age, avoiding excessive alcohol, and performing a bone mineral density screening above the age of 65 for females and above the age of 70 for males. So when should I see a doctor? As you can see, many people do walk with a severely curved back, but they seem to be coping quite okay. So not all cases of adult spinal deformity require medical attention. You should see a doctor if you are developing worsening symptoms, having new onset weakness or numbness, bladder or bowel incontinence, having progressive deformity, or having some additional red flag signs of a sudden loss of appetite or weight and a fever. So what does the doctor do? First, a comprehensive history will be taken, looking at the cause of your deformity, as well as the symptoms that you might be suffering from. Then we'll delineate the problem by doing X-rays, and in this case, this is an EOS scan, as was previously introduced by Dr. Ruben. And lastly, we may do MRI scans to delineate the positions of nerve compression within the spine. Additional blood tests may also be taken to look at any underlying causes which might be driving the deformity. So what can the doctor do for you? The doctor can prescribe painkillers, analgesia, physiotherapy. A course of acupuncture is sometimes useful for back pain, as well as radicular or shooting pain symptoms down the limbs. And advanced pain management options are also available, where injections can be given to the spine to reduce inflammation and to relieve nerve pain. Radio frequency ablation to various nerves around the spine may also be done if the pain becomes intractable and if surgery is not considered. Surgery is the very, very last resort. And this is because we have special challenges in adult spinal deformity. All the challenges which apply to adolescent idiopathic scoliosis, which is scoliosis for young people or individuals, do actually apply to patients with adult spinal deformity. And because they are generally more elderly at the age of about 60 to 70, they may have problems with their cardiovascular and respiratory health. They may have problems of anemia, which is low blood, renal disease, which leads to poor bone quality. And these may be chronic smokers, which also reduces the ability for bone to heal. Multiple complications are also present within surgery. Bleeding is a major complication, and as you can see, even in the best international hands, in an open surgery for major deformity, the average blood loss is up to 2 liters during the operation, and this can account to up to 40% of the patient's blood volume. Post-operatively, additional complications can occur, something such as proximal junctional kyphosis. This is where the spine continues to deform and tilt forward due to excessive amounts of stress and strain which is placed upon the spine and a fused segment. Lastly, nerve injuries and dural tears may occur during surgery, and dural tears lead to the loss of cerebrospinal fluid, which is the fluid that nourishes the brain as well as the nerves, and as can be expected, these can have very serious ramifications. So then what are the indications for surgery? The indications will include progressive deformity, intractable pain despite other measures, the presence of neurological deficits in a medically fit patient. I would never do this deformity correction for cosmesis alone. The aims of surgery are simple. It is to reduce deformity and to relieve nerve compression and symptoms. So how then does a surgeon plan for surgery? Well, I start by asking myself how I can do the least for the most amount of benefit to try and minimize the complications as much as possible. And to that end, I first consider the extent of the deformity, its location, my current technical capabilities, and finally, a surgical approach. This can be doing the surgery just purely from the back, or doing it from multiple incisions in a keyhole fashion, in a single stage or dual stage operation, depending on the complexity, as patients may have different underlying medical conditions which preclude a major corrective surgery in one sitting. To achieve a better outcome, we do have enabling technologies. This one, Dr. Ruben touched on previously, but I'll go through it a little more in detail. So we do have navigation, and this is based on an intraoperative CT scan of the spine, and this allows accurate placement of implants. We frequently use cell savers. These are machines which collect blood which is lost from the patient. The blood is then washed, filtered, concentrated, and returned back to the patient to avoid excessive blood loss. We also use neuromonitoring, in which electrodes are attached to the patient to provide continuous monitoring of the nerve signals within the body to try and prevent any inadvertent damage to the nerves which might occur during surgery. It also allows us to know if a nerve has been stretched too far when correcting curves. Adult spinal deformity also requires advanced implants, and these implants include specially cemented augmented screws, or cages which may be placed from the front of the spine or the side of the spine, cages that replace parts of the spine, and lastly, hooks or tapes, which may provide additional fixation points to prevent failure, as pointed out previously in proximal junctional kyphosis. On our horizon at SGH, we have new correctional capabilities where we can actually precisely plan the amount of bend or curve that we provide the spine instead of the traditional method by which it is estimated based on the experience and surgical skill of the operating surgeon. Now I have some case studies. So this is a 60-odd-year-old lady. As you can see, she actually stands with a severe forward tilt. And the analysis of the case revealed that there was a localized deformity at the lower part of her lumbar spine in L5 and S1. She had pain as well as difficulty walking long distances due to its associated nerve compression. This is her walking before the surgery. As you can see, she has a hunched back as well as flexed knees, and she now presents with a lot of muscle activation of her back just to try and keep her upright. After surgery, by straightening out her spine, she's able to stand upright and her walking is now much smoother. In my second case, this is an elderly lady who actually presented with back pain as well as acid reflux symptoms. She had early satiety, she couldn't eat, because you can see that the way her spine is curved is that it's compressing upon her stomach. She had attempted a long period of physiotherapy and conservative treatment, but she eventually elected to undergo surgery, for which she straightened out her spine. And what you can see on the right-hand panel is her 2 days after surgery, and I can tell you she's smiling under her mask. For the last case that I'd like to share today, this is a lady with immune arthritis. She has got rheumatoid arthritis and she had chronic pain as well as shooting pain down her legs. You can see she walks painfully and slowly with a hunched back. And after surgery, she walks much smoother, pain-free, and is actually able to bend and flex her body despite the large amount of fusion that had occurred. So my take-home messages are: 1, take care of your back as well as bone health. You only have one spine. It's better to prevent deformity than to have to fix it later. Adopt daily movement and muscular strengthening. Surgery is really the last resort. However, the results are worth it for the right patient. Thank you for your time.
Thank you, Ouyang, for the wonderful presentation. I'd like to thank all the speakers for keeping on their time frame. Now we are going to start off the question and answer session. Just a point of note, the entire webinar has been recorded, and subsequently it will be uploaded in the SGH Facebook page. So you can always re-listen to the entire presentation again, and all the slides will also be seen. We'll start off the question and answers. We have selected the questions, and many of them are somewhat similar. So we have picked up some of the representative questions, and the speakers will answer 2 questions each round. And we'll start off with Dr. Ruben So.
Okay, thank you. So the question here is, my niece at 30 years old has scoliosis of 38 to 40 degrees. Actually, I answered this question in the chat box earlier on, but I think I can share this again. Generally, for 38 to 40 degrees, if it's in the thoracic spine, which is the upper part of the spine, the ribs are supporting. So there's a good chance that it will not worsen over time. However, if it's 38 to 40 degrees in the lower spine, the lumbar spine, then there is always a slightly more increased chance of worsening. Although theoretically, we take the cutoff point as 45 degrees to 50 degrees for 1 degree or 0.5 degree of worsening every year. So because she is not at that severity yet, I feel that the main function she should do is to focus on core strengthening exercises. She should also keep her weight stable. She mustn't put on too much weight, particularly as she starts getting married and having children. And as long as she continues to have an active lifestyle and focuses on core strength, I think she should be fine without too much worry about her scoliosis giving her problems in the later life. Thank you. Okay, so for this question, I think that at 19 years old, most of our children will have stopped growing. So I feel that there will not be a role for bracing in these patients who is 19. And once again, I get asked this question quite often. Actually, there's no mattress that you really need to purchase. It can be, as long as it offers a firm rest for the patient, I think it's fine. There is no need to spend a lot of money on something that is supposedly for medical purpose or anything like that. So just a normal mattress will be fine. No need to, and of course, if it's not as well supported, I think it's sufficient. Thanks.
Okay, very good, thank you. Let's go on to Dr. Jun Kwek, and the question is there anything I have to be careful when doing Pilates?
Okay, thank you so much for your question. So I assume that this person who asked is an adult. If you do have scoliosis, tendency is that when you do exercises, there will be some level of asymmetry. So you may have to be a bit more aware of the way that you are doing the exercises so that it doesn't promote even further asymmetry. There was a patient that came in recently and she complained of some neck pain after going to the gym, and then asked her to demonstrate for me the exercises, and she could see herself that actually the way that she did her exercise, with a mirror as a feedback, she was actually doing it in a way that was not symmetrical, and using one side more than the other side, which then caused her pain. So just correcting that actually helped. So it doesn't matter what exercise you do, but I think the important thing is you have to perhaps have some level of feedback, either the mirror or your instructor, to ensure that the exercise is done in a balanced way. Next question. Okay. My scoliosis is not very serious. So far, still remain the same after so many years. Just like to know if it's okay to do Pilates. Yeah, so I answered this question. There's no specific exercise that I would recommend. Pilates is really good because it helps with flexibility, strength, mobility. I would caution though, for people who are not used to doing Pilates, don't start with the mat Pilates first. Perhaps you want to have a one-to-one session with the instructor. Start with maybe the reformer exercises, because those are less loading, more controlled environment, more close chain kind of exercises that helps with progressive loading. Often we do get patients who go for mat Pilates in a class of like 30 people, and then they get strain and pain after, because there isn't much monitoring. Yeah, so in general, I would recommend any kind of exercises, but someone who can actually give you some feedback and monitor your postures. Thank you. Next question.
Okay, so now let's move on to Dr. Ouyang. Let's flesh out his question. So the question was that this patient's scoliosis was discovered when he was age 44, when he started to have back pain. He thought he might have been idiopathic scoliosis. So how should he approach this?
So if you are having a back pain, it's always a good idea to schedule a consultation with one of our spinal specialists. It could very likely be due to adolescent idiopathic scoliosis. However, many people at the age of 44 also have back pain, which may not be associated with the scoliosis entirely. So a thorough physical examination as well as an investigation can be done together with pain relief by analgesia as well as physiotherapy will be done before deciding on any other follow-up management steps. Does scoliosis create any health problems or complications as we get older? In general, if you have a scoliosis that is not painful and is not associated with any symptoms, you can have an entirely normal life, even as you age. However, as a patient's age, again, disc degeneration can lead to an abnormal curvature of the spine, which will then need to receive a treatment in the form of physiotherapy and analgesia. It also depends on the degree of the deformity. Idiopathic scoliosis. Well, I believe that again, in idiopathic scoliosis who is asymptomatic, I think this can still be managed in the primary care. What I would look out for is any progressive deformity. So perhaps scheduling a patient for a 1-year follow-up with a repeat imaging of the spine would be useful.
Okay, thanks, Ouyang. Let's go on back to Dr. Ruben So, and the question from the healthcare provider is, when do you refer to a tertiary institution for the management of scoliosis, both adolescent and also for adult?
So I think for adolescents, scoliosis, the general practitioner or the doctor out there can do a Adams forward bending test, and if there is a significant prominence, they can actually download applications from the Google Shop or from App Store that can simulate a scoliometer, and then they can actually check to see what is the degree. But if there is a positive Adams forward bend test, then I think a X-ray could be done, and then they can then refer the patient on to the specialist. I think that the same can be said for the adult as well, but often the adult patient is a bit different. They may present more with nerve pinching symptoms, and they may also present with a bit of a slow progression of their posture towards one side called listing. So any patient that's listed by more than 2 centimeters should be referred to the specialist as well.
The next question, the participant asks, can my back be straightened without invasive surgery by either chiropractic or physiotherapy?
Okay, so I think that I have answered several questions about this earlier, but for now, we don't have any good data to support chiropractor treatment to improve the back scoliosis. I think that it improves it for maybe a few days or a few hours, but then soon after it falls back to the original position. And with regards to physiotherapy, it is important to see what's the context this is talked about. If it's an immature patient, they need the physio with the bracing, and the physio has also to be more scoliosis specific exercises. Whereas if it's an adult patient, I think the physio is important because it helps with core strength, and that prevents rapid deterioration. but I doubt that it will straighten the back back to its original shape, because much of the wear and tear is occurring in the disc and not in the bone of the spine. And so I think that this is a very short answer to a potentially very long question. Thanks.
No, that's a good answer, Ruben. And then one more final question for you before we release you is, have you heard about this surgery with EpiFix?
Yes. So EpiFix is a type of a device that's implanted into the spine, similar to the way that we perform scoliosis surgery from the back, but instead of exposing both sides of the muscle, only one side is exposed. And this is a type of surgery that can be done for a child that is still having some growth remaining. And in the same way, the exercises that are being done will over time try to allow this ratchet mechanism in the EpiFix to help the child straighten out over time. So it has been performed in Singapore, but the selection of the patient is very strict. So I think it needs a bit more time in the clinic to discuss further. Yeah.
Okay, thank you, Ruben. Let's go on to a question for Dr. Jun Kwek. Let's flesh out the question. The participant asked that he or she have scoliosis since primary school and have been suffering lower back aches for the past decade. He or she is now 45 years old. Recently been diagnosed with L5-S1 slip disc. So he's asking for some advice on what kind of exercises should I do to alleviate pain down my left leg. June?
Thanks, Dr. Goh. So I guess the question that I have is, what is the reason for the pain? It may or may not be related to the scoliosis. So I think it's hard to specifically give you an answer in terms of what exercises to do. But if the pain is not too serious, I would say any general exercises would actually help improve blood circulation, improve strength, and if that is the problem contributing to this pain, then it may help. For slip disc kind of issues, generally walking helps, but to a certain degree. So don't go to the point where you exceed the capacity of your body, but slowly, progressively build your tolerance to walking. I would say to see a physio so that the specific impairments can be worked out, and then we can then slowly address those issues, because not everybody with a slip disc are given the same exercises. It really depends on the mechanism of the problem as well as your impairments. So impairments, you're talking about strength, flexibility, and postural issues that we may need to address. Yeah, so it's very hard to, cannot really give you a specific answer, but yeah, in general, that's the principles.
Yeah, thank you, June. Yeah, sometimes it's difficult given, of course, it's in an open discussion format. The answers that our speakers can give is a generic answer. If you have a specific issue or specific medical problems, it's best seek a direct consult and advice. Let's go on to the next question for June, which is a common one. Maybe June can shed some light. What is the difference between a physiotherapist and a chiropractor? And can the chiropractor adjust the curve?
I think Dr. Ruben kind of addressed part of it. Yeah, I get asked this question a lot. I think the difference between physio and chiro is the principles behind the therapy. and chiropractors tend to be treating the spine for most problems. And for physios, we are pretty much impairment based. We work, we try to address patients' issues holistically. So not just really just physical, we also look at more broadly, you know, whether the patient has lots of stress in their life, their diet, their exercise levels, and then work through their physical problems as well. So we I'll say that we treat patients more holistically, whereas from my understanding, I might be wrong, the chiropractors are zoom very much into treating the spine. They claim that they can adjust the curve, but I think, like what Dr. Ruben said, it's perhaps temporary, and you have to keep going back to maintain that. So I would say that there are good chiropractors out there. It depends on their approach. Just as there's good physios and not so good physios, it depends on how they approach their management. Yeah, and I know some chiropractors actually also use exercises for their management and a more holistic approach. So I think the main difference is the training and the principles behind the approach. Yeah.
Okay, thank you, June. And let's go to our final pair of questions to Dr. Ouyang. The participant asked, is a scoliosis patient more predisposed to severe hunchback when he or she gets older? Ouyang?
Yeah, so there is a mild association with increased hunchback in the old age with a patient with scoliosis. However, this increase is not significantly different from that of the general population. One of the questions I get when I treat young patients with scoliosis is I frequently tell them that despite the period of observation in their adolescence, it does not mean that they're going to progress on to severe deformity in the future, and that these can be treated as two separate things. However, in a patient with pre-existing scoliosis, it does make surgery a little more challenging as the muscles and some of the shapes of the bones may be slightly different in a patient with pre-existing scoliosis. I hope that answers your question.
The next question is to the participant. Surgery seems really successful for younger patients who are still maturing. What would be the surgery and success rate for older patients? Ouyang?
In general, this would depend largely on the degree of the curvature, the degree of the deformity, and its location. In general, I would say that older patients do have lower success rates together with higher complication rates. Here in SGH, with patients with major spinal deformity, we quote them up to about 10 to 20% risk of immediate post-operative complications. And in the longer term, if there are other complications such as proximal junctional kyphosis, where there is a wearing out of the junctions above or below the area where surgery was performed, this can be up to about 2 to 3% per year, each year after surgery. So the cumulative overall complication rate of major spinal deformity correction can be up to 30–40%.
Okay, thank you, Ouyang. I'd like to take this opportunity to thank all the speakers this morning, Dr. Ruben So, Dr. June Kwek, and Dr. Ouyang, for presenting and sharing their thoughts and their experience in scoliosis. It is a very, I would would say, common problem in the general public. And as you can see, that we actually have many participants and many questions that are fielded. Unfortunately, we can't answer every single one of them, but this webinar would be actually have been recorded and it's going to be telecasted in the SingHealth Facebook web page. So if you go to the SGH and SingHealth website, you can actually revisit and watch this webinar, and all the slides will be seen and shown again. Just a point of note, we hope that this webinar provides you with some understanding and on the basis and some help for managing scoliosis on a personal basis. But if your condition is severe or you feel that there must be something wrong or amiss, it is highly recommended that you actually seek a professional opinion. You can actually locate any of the doctors, both Ruben and Ouyang, and also June, Dr. June, our physiotherapist. You can use any of these three methods. You can do a self-referral. That means directly call SGH Central Appointment. There's a line, and you can just scan the QR code that you see. If you like a specific referral to a certain doctor, you can go through a GP or a polyclinic. So both ways you can access both the primary care doctor to get some advice on whether your condition is pertinent for orthopedic referral. With that, I'd like to thank both the speakers and all the participants for your time on this Saturday morning. We hope it has been informative and relevant to you. Thank you, everybody. With that, I'd like to call this webinar to a close. Okay, bye-bye.